The next session will be on heart failure. The chairperson for this session will be Dr. Dipankar Mukherjee, Dr. Shankar Mondol, and Dr. Spandan Bhaduri. The moderator for the session will be Dr. Vishwajit Majumdar, and the expert panelists will be Dr. Vineet Kumar, Dr. Bipin Kumar, Dr. Shaumokanti Dotto, and Dr. Amit Mittal. May I request the chairperson and the moderator to please proceed with the session.
Yes. Good evening.
Good evening, sir.
Now, as we are already late, we start with the first talk. The speaker is Dr. Arijit Ghosh. Dr. Arijit Ghosh, please.
Audio is not audible.
Not audible? Hello?
Yes, sir.
You are audible.
I am audible.
Yes.
Yes.
Dr. Arijit Ghosh is here?
Are my slides visible?
Yes.
Yes, sir. Yes, slides are visible.
Yes. Not audible.
So without wasting much time, respected chairpersons and moderators, today my topic discussion is how to sequence heart failure regimen. So this will be my outline of discussion.
Any issue, sir? You're facing any issue?
The slides are not moving.
So kindly click on, yeah, it's moving.
So we have seen that there has been a dramatic improvement in the survival of our patients with heart failure with HFrEF. And this is because of the most widespread implementation of disease-modifying pharmacological therapies supported by the landmark trials. But still, in the real world, we find that the novel agents like the ARNI and the SGLT2 inhibitors are used quite rarely. So these are the foundational therapy which has been tried in the various clinical trials that are tried ACE inhibitors along with beta blockers and MRA, and this continues to be the foundational therapy for our heart failure patients. And it has been proved time and again since the last 3 decades that combining various drugs acting on the various pathways have an incremental mortality benefit. So what do we have in our armory in 2021? In 2021, we have ARNIs, SGLT2 inhibitors, vericiguat and ivabradine as new tools in our kit. So how do we reach here? Heart failure guidelines are based on inhibition of RAS and sympathetic nervous system, and that is why ACE inhibitors and beta blockers become the cornerstone of our therapy. And in both the European and the American guidelines, we find the addition of additional drugs such as MRA in patients who still continue to be having LV dysfunction, as well as the patients who are still continuing to be symptomatic. And these guidelines differ subtly regarding the timing of MRAs relative to other therapies, but otherwise the things are quite similar in the different guidelines. So to start with, we find that in the recent ESC guidelines, they ask us to start with an ACE inhibitors and beta blockers, and if the patient still continues to be sympathetic, we gradually add on MRAs, and then we keep on adding ARNIs and ACE inhibitors. Same is the story in the ACC/AHA guidelines as well as the Canadian heart failure guidelines. But the unique thing about the Canadian heart failure guideline is that we start with triple therapy, ACE inhibitors, ARBs, and MRAs since the outset, and then depending upon the non-response, we keep on adding the other group of drugs. This is a very interesting slide where we see that in the CHAMP registry, we find that even in US, in the patients who are attending the OPD, how the drugs are underprescribed and how the drugs are underdosed. As we all know that receiving suboptimal doses of GDMT increases mortality. So the current approach suffers from various limitations. First, it assumes that most of our effective drugs and the well-tolerated drugs were developed first, but this is not true. Second, it assumes that the foundational treatment are effective only when titrated to target dosage. Third, it assumes that the efficacy and safety of each drug class were tested in clinical trials that required the patient to be receiving all background therapy at target doses. And this is the timeline. As I've said, that ACE inhibitors and ARBs were invented first, so they are considered to be the most effective therapy, which is followed by the beta blockers, which come next in the timeline. So beta blockers becomes the next add-on therapy, and subsequently you find that MRAs, which were discovered in 2011, and paradigm heart failure trial in 2014, and subsequently the DAPA-HF trial in 2019. So this is the timeline of the various trials. As I was saying, that not in the future trials, not all the patients were receiving guideline-directed medical therapy. That is why in the well-designed paradigm for heart failure trial, we find only 56% of the patients receiving MRA. While in the DAPA-HF trial, we find only 2/3 of the patients receiving MRA. So they were not on optimal medical therapy. And we also see that in the DAPA-HF trial, only 11% of the patients were on ARNI. So the issues with conventional therapy, if the physicians prioritize the achievement of the target doses of each drug classes, it may take about 6 months or more to prescribe all the recommended classes of drugs. A delay in 6 months is unacceptable since each of the foundational drugs have shown to decrease mortality within 30 days. With every passing visit, the absence of one or more of the therapeutic agents results in unnecessary risk of hospitalization and death. So we come with new algorithm. The basic premise is, first, the magnitude of treatment benefit of each class of drugs is independent of that produced by other agents. Second, low starting dose of the foundational drugs are effective in reducing the morbidity and mortality. We don't have to reach the maximally tolerated dosage. Third, the addition of a new drug class yields benefit that is greater in magnitude than up titration of the existing classes of drug. Fourth, the proper sequencing of the drug classes can improve the safety and tolerability. Specifically, neprilysin inhibition can reduce the risk of renal insufficiency produced by an ACE inhibitor or ARB, and both neprilysin inhibition and SGLT2 inhibitors can minimize the risk of hyperkalemia seen with MRAs. Fifth, and most importantly, because much of the benefits of the foundational treatment are seen within 30 days of initiation of treatment, the algorithm should achieve the therapy with all 4 classes of drugs within 4 weeks. So this is our conventional sequencing, where we find that ACE inhibitors, beta blockers, and MRA are added sequentially. But in the current proposed sequencing, we find we have been asked to start with the beta blocker and SGLT2 inhibitors. And depending on the response and the tolerance of the patients, in the next 1 to 2 weeks, we start ARNI, and followed by addition of MRA in the next 1 to 2 weeks. So we get all the main cornerstone of therapy added in our regimen within 4 weeks of initiation of therapy, which is very important. Principle on which the recommended algorithm is based: simultaneous initiation of treatment with beta blockers and SGLT2 inhibitors. Beta blockers have been considered to be the most effective drug class for treatment with HFrEF, with a mortality reduction of almost 35%. SGLT2 inhibitors have a striking effect to reduce the risk of hospitalization for heart failure, and this benefit may mitigate the short-term risk of worsening heart failure when treatment is initiated with beta blockers. So far as comprehensive therapy is associated with 8.3 more event-free years versus conventional therapy in symptomatic patients. What do we actually mean by a comprehensive therapy? A comprehensive therapy means addition of beta blockers, ARNIs, MRAs, and SGLT2 inhibitors at the same go. So the ACC 2021 recommends recommendations regarding GDMT optimization. To achieve the maximal benefit of GDMT in HFrEF patients, therapies must be initiated and titrated to maximally tolerated dose. Target doses are associated with best outcomes, and titration should occur even if the patient appears to be stable or their symptoms and/or heart EF improves. Beta blockers should be increased every 2 weeks. So, to conclude, while others have suggested the initiation of beta blockers along with SGLT2 inhibitors, it is not that these are the only 2 drugs which has to be initiated initially, but the exact sequence of initiation of the drug is not important, but as long as all the 4 pillars of drugs are introduced within the first few weeks of diagnosis. This is what is much more important. So this can be the proposed algorithm, and we are waiting for the guidelines to change. That is, along with the conventional therapy to start with, we can straight away add SGLT2 inhibitors at the outset. So to conclude, do we require anything more? Yes, because if we don't, our patients will suffer. And if we are complacent, we cannot be complacent as because our patients deserve more. And the sooner we act, it is better for our patients. Thank you.
Thank you, Dr. Arijit. Very nice disposition and good take-home message. So, is there any mean to say that the individualization of therapy is to be adherent or start with all the 4 drugs?
Sir, it is always better that we add various drugs acting on the different pathways rather than trying to titrate a single group of drug to its maximally tolerated dose. If not the maximally tolerated dose, at least up to the optimally tolerated dose. Because when we try to address different pathways, it becomes much more beneficial for the patient in terms of decreasing mortality or in terms of decreasing the future hospitalization.
Over to Dr. Biswajit Majumdar.
Now, Arijit, I have one question for you. Now, what is your recommendation of using the ivabradine on top of beta blocker or as an isolated therapy in the heart failure with reduced ejection fraction?
So far as the usage of ivabradine is concerned, it still continues to be a class 2A indication, and we first use beta blockers at an optimal dosage, and if not the maximally tolerated dosage, and we try to keep a heart rate of less than 70. And if the patient does not respond with a heart rate of less than 70 within 2 weeks of titrating beta blockers up to the maximal tolerated dose, then we can add ivabradine on the top of that. And there might be some patients who don't tolerate beta blockers well. So these might be a group of patients where ivabradine can be used. And the third is, especially in the acute heart failure situation or an acute MI, where we are not in a position to initiate beta blockers, ivabradine might be a good alternative in this situation where decompensated heart failure patients with increased volume overload is considered, and we have to decrease the heart rate so that we can have some improvement in the heart failure status.
So do you think that this combination will have a better mortality over the either agent alone?
If the heart rate, because ivabradine, in most of the trials, ivabradine has been effective by decreasing the heart rate. If the heart rate is achieved by giving optimally tolerated dose of beta blockers, I don't think that ivabradine will be of much help on the top of beta blockers. But if the heart rate is not achieved, then we can think of an increased mortality benefit with the usage of this combination of beta blockers in ivabradine.
Yes,
As we are running late, I will request the next speaker, Dr. Soumik.
Thank you, chairpersons. So a very good evening to everyone. Now, I've been told to talk about SGLT2 inhibitor FDCs in heart failure, and SGLT2 inhibitors are interesting drugs. It's because they have reduced the number of times our patients visit cardiologists, but at the same time, they have ensured that cardiologists and endocrinologists meet each other much more frequently, at least in academic platforms. And there exists a similar paradoxical relationship between blood glucose and heart failure, whereas bad glucose control is associated with increased risk of heart failure. Improving blood glucose levels, on the other hand, have not shown a decrease in heart failure in a number of studies pooled together. However, if we talk of patients with established heart failure, again, we don't have any data whether blood glucose control per se would be good or not. But what we do know is that unless you control blood glucose well, you can have more infections, you can have more dehydration, you could land up in ketoacidosis, as well as you could increase the risk of other vascular complications like retinopathy, nephropathy, and lead to a worsening of quality of life of your patient. Now, when we talk of heart failure and when we talk of anti-diabetic drugs, the aim now, after the advent of SGLT2 inhibitors, would possibly not be only good glucose control, but to give additional pleiotropic benefits to our patients with heart failure. And when we talk of SGLT2 inhibitor fixed dose combinations, the 3 combinations which pop up at least in the Indian scenario in front of us, are empagliflozin linagliptin, dapagliflozin saxagliptin, and remogliflozin vildagliptin as a fixed dose combination. Now, what we'll do is we'll have a look at the SGLT2 inhibitor part and the DPP4 inhibitor part separately, because use of FDCs, either of these three FDCs in patients with dedicated heart failure, has not been studied in any dedicated trial and will possibly not be studied in any trial in the future. Now, talking of SGLT2 inhibitors, we know that we have trials where SGLT2 inhibitors were used in sort of preventing heart failure in patients without heart failure as a secondary outcome, and as a primary outcome, it was also tested in trials in patients with established heart failure. Again, if you look at trials where prevention of heart failure was looked at as a secondary outcome, across the SGLT2 inhibitors, this benefit was persistent. But at the same time, we know that in terms of atherosclerotic cardiovascular disease outcomes, in terms of cardiovascular death outcome, there happens to be a within class difference between these agents which are used to treat diabetes. And I won't go into the details of that. But if you look at the EMPA-REG trial, which again was not a dedicated heart failure trial, but had patients with atherosclerotic cardiovascular disease, it was seen that those with established atherosclerotic cardiovascular disease who did develop a heart failure during the course of EMPA-REG trial, the incidence of developing a heart failure for a second time or dying from heart failure was reduced significantly with empagliflozin compared to placebo. So it was sort of a subgroup analysis of the EMPA-REG trial, wherein patients with established ASCVD, if you develop heart failure and you were on empagliflozin, the risk of developing it again or dying from heart failure was significantly reduced with empagliflozin. So this was another trial which tried to look at it in a different way, and the outcomes were the same. The outcome was that if you had ischemic heart disease and you developed heart failure, and if you were on empagliflozin, your risk of dying subsequently was significantly reduced compared to placebo. With empagliflozin, we also have the EMPEROR reduced trial, a dedicated trial of heart failure, where use of empagliflozin in patients with and without diabetes with established heart failure led to an improvement in both the primary endpoint as well as the secondary endpoint. However, we know that in this trial, one of the specified secondary endpoints, cardiovascular death and all-cause mortality, did not decrease with empagliflozin, although the pre-specified key secondary endpoint as well as the primary endpoint did improve with the use of empagliflozin in patients with heart failure with reduced ejection fraction. This trial also told us that in patients with established heart failure, when you use an SGLT2 inhibitor like empagliflozin, you get to see the benefits in terms of preventing mortality or worsening of heart failure within the first 12 days. So benefits with SGLT2 inhibitor like empagliflozin begins within 2 weeks. With dapagliflozin, again, we have a similar trial, that DAPA heart failure in patients with reduced ejection fraction in both with and without diabetes. Dapagliflozin helped to reduce the primary endpoint as well as the individual components of all of the primary endpoint. All of them were significantly improved with the use of dapagliflozin. And unlike the EMPA heart failure trial, here interestingly, the cardiovascular death and all-cause mortality also decreased with the use of dapagliflozin in patients with established heart failure. Although I must put out the caveat that these were secondary endpoints and these had a fewer number of events happening. The trial was not primarily designed to look at that. What about remogliflozin? At this point of time, there is no dedicated heart failure trial with remogliflozin, but recruitment is going on for a proof of concept trial with remogliflozin will be compared with empagliflozin in patients with heart failure, but we don't have data as of yet. Regarding the DPP4 inhibitors, again, if we look at trials which did not include specifically heart failure patients, we know that saxagliptin was a villain in terms of increasing hospitalization for heart failure. The Carmelina trial had about 1/4 patients with established heart failure at baseline, and in them, linagliptin did not further worsen outcomes. Similarly, in the PCOS trial with sitagliptin, about 1/5 patient had heart failure at baseline, and sitagliptin did not further worsen outcome in these patients, although we don't have a fixed dose combination of SGLT2 inhibitor and sitagliptin. Now, with regard to vildagliptin, there was a smaller trial, the VIVID trial, about 250 patients, which included patients who had a mean baseline ejection fraction of around 30%, in whom 1 year use of vildagliptin did not lead to further worsening of heart failure, did not lead to any significant change in ejection fraction compared to placebo, sort of providing a proof of concept that vildagliptin could be safe in patients with established heart failure. So where does that leave us? If you look at the SGLT2 inhibitor and DPT4 fixed dose combination, possibly the best data belongs to empagliflozin-linagliptin, where linagliptin showed its neutrality in a subgroup analysis of the Carmelina trial. Empagliflozin showed its benefit in the Emperor reduced trial. The second in hierarchy would be dapagliflozin-saxagliptin, where dapagliflozin showed excellent results in terms of improving both the quality as well as the quantity of life in patients with heart failure in the DAPA heart failure trial. Saxagliptin, however, had a warning to it in terms of increasing hospitalization for heart failure, although the expectation would be that when used with dapagliflozin, possibly this extra risk of heart failure would be mitigated with the use of the SGLT2 inhibitor. In terms of Remo-Vilda, again, although it is expected that as a class effect, heart failure would be improved with the use of remogliflozin as well, we don't yet have the REMIT heart failure results available. With vildagliptin, at best, the results would be neutral, so I would place it third in the hierarchy of use when it comes to SGLT2 inhibitor, DPT4 inhibitor combination. But are we forgetting something when we are talking of an SGLT2 inhibitor, FDC fixed dose combination? We are possibly forgetting metformin, because metformin is available in combination with SGLT2 inhibitors. And over the last 10 years, there have been studies published which have suggested that in patients with established heart failure, use of metformin might lead to a decrease in all-cause mortality and cardiovascular mortality. So from villain, metformin has now turned into sort of a supporting actor, if not the main actor in patients with heart failure over the last 10 years. And the ESC 2016 guidelines was the culmination of evidence which said that you can use metformin as first line in patients with established heart failure as long as they are not in an acute hypovolemic state, they do not have associated renal dysfunction or hepatic dysfunction, because otherwise the overall risk of lactic acidosis is quite low in stable heart failure patients, and you could additionally reduce mortality. The exact mechanism is not known. It could be because of AMP kinase activation, because of reduction in cardiac fibrosis, improvement in the glucose transporters, increased glucose utilization by the heart. But there are studies which suggest that metformin could reduce mortality in heart failure. So with this knowledge, my final slide to look at the hierarchy of use of SGLT2 inhibitor, FDCs in type 2 diabetes mellitus with heart failure, I would put dapagliflozin and metformin at the top of the heap, because of two reasons. One, the economy of use. Now with generic and economical versions of this molecule being available, it could be prescribed to a greater number of patients. And of course, in the DAPA heart failure trial, there was an improvement in the secondary outcomes of cardiovascular and all-cause mortality. This would be followed by empagliflozin metformin. Metformin showed benefit in observational studies. Empagliflozin showed benefit in the Emperor reduced trial. Followed by empagliflozin linagliptin, where linagliptin would be neutral with empagliflozin showing benefits, followed by dapagliflozin saxagliptin. If cost is a concern, if you cannot use an FDC, you can use dapagliflozin vildagliptin separately, as both of these are available as generic formulation. And at this point of time, I would keep remogliflozin vildagliptin at the bottom of the heap, at least till the publication of the REMIT heart failure trial. I would like to end with the message that we must select our horses depending on the courses. There is a need and there is a place of use of almost every FDC that is available in the market. You have to choose your drugs wisely depending on your patient's condition. So I end my part there and hand it back to the chairpersons.
Very, very good lecture and comprehensive and emphatic. We have got our expert panel. Expert panelists, please put your opinion. There are 4 experts. Dr. Majumdar, as moderator, just take up the.
Dr. Goswami, thanks for a nice and excellent talk. Now, when patient comes with heart failure, definitely we will choose SGLT2 inhibitor in diabetic, even in non-diabetic patient, when there is no cross contraindication. Regarding management of diabetes, what is your initial choice? So in patient who have not established heart failure but diabetes above 40, there is no contraindication of SGLT2 inhibitor. You will include SGLT2 inhibitor in all patients at the initiation of therapy?
So now I think with the available of more economical versions of dapagliflozin, in at least a big fraction of patients, even middle-aged patients, SGLT2 inhibitor is replacing DPP4 inhibitor as the first add-on along with metformin. Even I would say with the presence of a single cardiovascular risk factor, it could be anything. It could be obesity, albuminuria, smoking, family history, hypertension, dyslipidemia, anything. I would prefer using an SGLT2 inhibitor over a DPP4 inhibitor along with metformin in newly diagnosed patients.
Yes, thank you. And regarding next question, what is your role of SGLT2 inhibitor in prevention of progression of CKD in diabetes? Do you consider it better than AC inhibitor or ARB?
I think we don't have any I understood. We don't have any head-to-head data in all the trials where it was tested in patients with CKD. It was used on top of standard of care, which was a RAS inhibitor, either a ARB or ACE inhibitor. So it was on top of ACE or ARB, not versus an ACE ARB. So it has to be used in that fashion.
Thank you.
I have one question to Dr. Goswami. Now, most of the patients who come to us for the management of diabetes, hypertension, etc., on the clinical side or from the echocardiography or ECG, they don't have any telltale sign of coronary artery disease. But we know that, can you hear me?
Yes, sir, definitely. I can hear you.
We know that the diabetes, type 2 diabetes is considered to be a cardiovascular risk equivalent. So whether he is symptomatic or not, or he has got any evidence from the ECG or echo, any ischemic heart disease. Now, my point is that in that scenario, will you start with the empagliflozin or will start with the dapagliflozin?
Sir, in the absence of evidence that there is established ASCVD, it could even be a peripheral arterial disease where I would prefer use of empagliflozin. But if anything is not there, not even peripheral arterial disease, leave alone any evidence of ASCVD, the choice is open between the SGLT2 inhibitors, and I think I would prefer dapagliflozin in the majority of my patients, given that it is more economical and it's more pocket friendly for the majority of my patients.
That is valid point because of the economic reason, but many patients of type 2 diabetes do have the silent myocardial ischemia that they can experience sudden cardiac death because of the coronary artery disease. So from that point of view, SGLT2 inhibitor as cardiologist, I think because the empagliflozin takes care of prevention of cardiovascular death from the coronary artery disease, besides the recurrent hospitalization or prevention of heart failure. So from our point, at least from my point of view, besides the consideration of the price, I'd rather prefer the empagliflozin in place of the dapagliflozin to prevent the coronary artery disease, which is not symptomatic, but can lead to sudden cardiac death or heart failure, will be a preferable agent as compared to the DAPA.
I absolutely agree with you, sir. Even if you talk of pure science, I think you can use it along with, say, a GLP-1 receptor agonist in most patients with type 2 diabetes, but practically, it's not possible in most patients.
Okay,
thank
you. Dr. Amol Khan, we are running late. Only one question, okay.
Dipankar, ask Amol Khan place one question.
Dr. Amol Khan, you
are muted. Sir, you are muted, sir.
You are muted.
Very nice spoken, Somit. It's exactly enlarging our knowledge also. But I want to ask you one question, only a small issue, that you have put metformin and SGLT2 inhibitor above DPP4 inhibitor plus SGLT2 inhibitor. Do you have any evidence in favor of that?
There would be two evidences in favor of that. One, in systematic reviews and overall, the glucose lowering ability of metformin surpasses that of DPP4 inhibitors in terms of HbA1c lowering. This would be point one. Point two would be, at least in observational and retrospective studies in patients with established heart failure, metformin has reduced all-cause mortality and in some cardiovascular mortality. With the DPP4 inhibitors, it's absolutely neutral. There is no benefit even in observational studies. So given these two facts, I would put a metformin above a DPP4 inhibitor.
That
Thank you.
that means from your endocrinology point of view, that SGLT2 inhibitor along with metformin has edge over DPP4 inhibitor. Only you suggest
SGLT2 inhibitor plus metformin has an edge over SGLT2 inhibitor, DPP4 inhibitor.
is a better combination, and it should be used prior to using even DPP4 inhibitor plus SGLT2.
Yes, yes.
I'm not going into this question that whether MPA is better or DAPA is better or CANA is better.
So, but most patients would actually require all three drugs, metformin, SGLT2, DPP4 inhibitor. So at the end of the day, practically we need to use all of these agents in combination.
Thank you, Dr. Soumi Goswami. Thank you. Please, we are running late. Questions will be later. Now we'll switch over from drug therapy to electrical therapy, and our speaker is Dr. Aparna Jaiswal. She is ready.
Thank you so much, sir. Am I audible?
Yeah, totally.
Yes.
Very good.
Thank you so much, sir. And I think we are entering into a very exciting area, and also the domain itself is very exciting, where I have been entrusted the task of speaking on CRT versus CSP in this heart failure symposium. At the outset, I'd like to thank the organizers for giving me this opportunity to be here. And I would very clearly make it that when we speak on CRT versus CSP, I think we must understand that today CSP, the conduction system pacing, is making an attempt to enter the domain of CRT, which is an established therapy for heart failure. And it seems to me at the end of it, they would most likely complement each other rather than compete with each other. So when we talk of cardiac resynchronization therapy, CRT has traditionally been performed by using the biventricular pacing technique, in addition to guideline-directed medical therapy in patients who have HFrEF and ventricular dyssynchrony on their EKG, and we see that the QRSD is more than 150 milliseconds, and preferably they have a left bundle branch block. The robustness of data gives us the confidence to include patients for CRT, because we know that there has been an improvement in their quality of life, their exercise capacity, cardiac function and structure. It reduces heart failure hospitalization, and it was a landmark CARE-HF trial, a large trial which told us that there was mortality benefit also with CRT-P, which did not contain a defibrillator in it. However, I think this remains a problem for the physicians, as well as even more so for the implanting physicians, the issue of non-responders. Whenever we implant a CRT all over the world, it is extremely distressing for the implanting physician, most of all, as well as for the physician and the patient together, because we see the non-responder rate of CRT anywhere between 30 to 50%. And it has been noted that the cause for this non-response are varied. But most important, which needs discussion, is when we implant a CRT, the problem we are compounded with is a suboptimal left ventricular lead position. And as an implanting electrophysiologist, it remains the most important task during the procedure to identify the sweet spot, because we do understand that the determinant of a successful CRT is truly, after having selected the appropriate patient, the position of the LV pacing lead. It was much earlier that we had realized that when we implant CRT in patients who have left bundle branch block, we wish to activate the lateral or the posterolateral part of the left ventricle, and everybody, all the implanting electrophysiologists, went ahead and gave the implanting LV lead in that zone. However, subsequently, as we saw that despite giving the lead at the sweet spot, the patients were not responding. So they did several studies which were invasive with conductance catheters positioned in the left ventricle, and tried to see if we paced epicardially or paced endocardially in the left side, in the left ventricle, lateral or posterolateral area, were we getting the adequate response? It was clear that we were not getting the adequate response in all the patients, even if we paced in the lateral left ventricular wall. So much so, one group from Derwal said that the lateral left ventricular wall and coronary sinus may rarely be the best sites, which brings us to the point that despite CRT, optimal LV pacing site cannot be defined a priori and is specific to each individual. The reasons are many, but most important, The coronary sinus, which is the conduit to carry our LV lead, is not always the ideal conduit to reach the sweet spot. And there are several reasons for that. One, we always can be challenged because of poor coronary venous anatomy. There could be a scar in the left ventricular lateral wall, resulting in high thresholds. And of course, what is most distressing for the electrophysiologist and uncomforting for the patient is the unavoidable phrenic nerve stimulation in a few patients, which brings us that we have to have alternative techniques to allay the dyssynchrony of our patients. And what we have today is the conduction system pacing, which encompasses the pacing both at his bundle as well as left bundle area. So what is conduction system pacing? Conduction system pacing basically involves the placement of a pacemaker lead in the areas of the atrioventricular conduction in a point where the disease is proximal and we pace distal, as a result of which we capture the conduction system and we bring about patient's electrical resynchronization by conducting the electricity via the patient's own intrinsic conduction system. So what are the sites that we use for the conduction system pacing? We could either capture the bundle of his, or we could do left bundle branch pacing. We may also opt for left septal pacing, and I also show you the position 4, that is left ventricular epicardial pacing. The reason I show you this, as we talk in the next few slides, there will be a mention of this. So when we say his bundle CRT, we imply that we are capturing the bundle of his. This has its own inherent issues. We understand that his bundle is actually insulated and deep down in the membranous septum. Now this his bundle, the issue here we see is the patients have higher thresholds and they have sensing issues. There are oversensing because, as you can see, it is very close vicinity to the atria. So they can be oversensing and higher thresholds. While we have the left bundle branch pacing with CRT, it is in this zone. We could also use what we call bi-CRT, wherein we pace the LV from here and we have a lead in the right ventricle. Or we could do hot CRT, which means we have one lead in the his bundle and we have a coronary sinus lead going and pacing in the LV epicardial area. You could also do a lot CRT, which means we do left bundle branch area pacing and have a coronary sinus lead pacing in the left ventricular epicardial area. So these are the potential sites for conduction system pacing and CRT. And what is the background? The background dates back quite old, and the rationale is of creating the physiological activation of the ventricles, as I just showed you. And it was as early as 1977 that Dr. Narula demonstrated left bundle branch correction by his bundle pacing. However, it was Dr. Deshmukh and their group that in the year 2000, they attempted his bundle pacing in those patients who had atrial fibrillation with very fast ventricular rates. So what they did was they did the AV junction ablation in a very small number of patients. And in those patients, they gave the his bundle pacing, and it was very rewarding. And that's when the foundation was laid in the recent years. Technological advances have made it possible, and it is being increasingly used. The issue remains, as I will follow you through, there are large RCTs are still awaited, and long-term follow-up is truly missing. So this diagram actually is a blow-up of what you are seeing is the conduction system. When we talk of his bundle pacing, we imply it is in this zone. We could either have selective his bundle, wherein it is the lead is actually it is capturing the his bundle. It could be non-selective, where it is capturing the adjacent myocardium as well as the his bundle, or it could be myocardium only. Now, I showed you that there is, after his bundle, there is also left bundle area pacing, and these are different sites. Typically, what we attempt is in the left bundle branch pacing, we take our lead from the right side, we go across the septum, and we capture the main trunk of the left bundle here, and as a result, we attempt that the block is proximal, and we are able to recruit the bundle branch fibers of the left side, and we are eliminate the left bundle branch block. The tools have made it more and more possible, and they are all in the offing. And these are tools from the large industry makers. We have largely dependent upon Medtronic. The sheets that we're using is C315, which is basically available in India. And there is only this one lead, which is a very interesting lead. This is a lumenless lead with an exposed helix, which goes and we screw it in the bundle of his or in the left bundle branch area. We have Medtronic, Abbott, and as well as other players in the market. The conduction system pacing, when we do, we have a success depending upon the center which is being done to the tune of 70 to 80% with the utilization of special guiding catheters, which I just showed you. You could either do a selective His capture. As you can see here, the QRS is so narrow. You will always find when you see a selective His capture, there will be a spike and there will be an isoelectric line as just akin to an HV interval. Or you could have a non-selective His capture. If you look more carefully, there's a spike and then there's a delta. What does it imply? It implies, as I showed you in the previous slide, it captures both the local and the adjacent myocardium and the bundle of His. As a result, just like a Wolff-Parkinson-White, you find the presence of a delta. There could be correction or not correction of the bundle branch block, because if the disease is distal, you may not be able to correct the bundle branch. The problem, as I told you, with his bundle is it's in small area. You may be problematic with a high pacing threshold and lower sensing, the need for lead revision, and of course, a backup lead. The potential indications of conduction system pacing, it can be used in lieu of RV pacing in patients with AV block as a part of, as I told you, what Dr. Deshmukh's group did, AV nodal ablate and pace, in lieu of CRT, when CRT fails, and hot CRT. I think what is pertinent to our lecture here is these, but that's why I don't want to talk about his bundle in lieu of RV pacing or his bundle in pace and ablate. But yes, it seems encouraging even in these areas that we could attempt his bundle in lieu of RV pacing. Coming to his bundle for CRT, it's encouraging to note that his bundle pacing corrects about 50% of left bundle branch. It has been reviewed in several studies, but look, several studies, and we have a very small number of patients, and that is one of the fallout of this. The small studies have demonstrated that ejection fraction and clinical improvement happen, including cases of rescue CRT. The meaning of rescue CRT is those where the patients were unable to get the CRT because there was non-available of the vein. The results are similar or better than CRT in small non-randomized study from these authors. And we have also encouraging data that even patients of right bundle branch block, which are often eliminated when we are attempting a CRT, can be given his bundle pacing and they have done better. So these are several studies. I don't want to go into detail for the want of time. But the first person who did his bundle pacing in CRT with DCM was Barba, the group of Barba from 2013, and subsequently there were several that followed. You could look here. They're very small studies, and that truly is the major fallout, that we don't have the robustness of data as we have in our CRT trials. But what did we learn from his bundle pacing in patients when they were given for CRT? That it improved patients' NYHA class, and it demonstrated that his bundle was feasible and a safe alternative to CRT, improved NYHA, and reduced the QRS duration. Similarly, his bundle pacing in right bundle branch block, as I told you, it improved the patient's NYHA class, and it appears to be a reasonable therapy for patients with right bundle and depressed EF, which largely actually do not receive CRT. So this is again trying to show that when they did his bundle pacing in patients who failed BIV or were rescued BIV, or did his bundle pacing in patients who did not need a BIV but needed just a pacemaker or a ablate and pace, in all of this group together, it was extremely encouraging that the patient's NYHA class dropped at least 2 classes. Again, his optimized CRT was a feasibility study which was done in 2019 by Dr. Vijay Raman, and it was a very interesting study. Very small. They had just about 29 patients. What they did, they gave a his bundle lead, and they also gave an LV lead, and they looked at what happened to these patients, and the results were encouraging. So his optimized CRT was conducted by Dr. Vijay Raman as well as Dr. Deshmukh. However, there were several challenges with his bundle. The largest challenge, increased capture thresholds and increased sensing. The interest moved by Dr. Huang to left bundle branch area pacing. And there were several advantages because I showed you there was a larger area to capture, there was a higher success, better and more stable thresholds than his bundle pacing, and no risk of AV node ablation. There were several disadvantages. And the most important, which we do worry about today, is septal perforation, problem with septal scar, and this is what is most important: no long-term results. And as electrophysiologists, we truly worry about extractions. Left bundle branch area pacing has also been reviewed in 7 studies, and it was Dr. Huang in 2018 which made the lead. And as you can see here, there are several studies which have done with encouraging results that is feasible and it may be an alternative to CRT. So this is from the latest ESC which took place. We still have the guidelines and they will be coming out in August of 2021. But what have we learned? The recommendations that have been given in the latest ESC are that in CRT candidates in whom coronary sinus lead implantation is unsuccessful, his bundle pacing should be considered as a treatment option along with other techniques such as surgical epicardial lead, and the class of recommendation is 2A with level of evidence being B. Also, his bundle pacing with a ventricular backup may be considered in patients with pace and ablate strategy where it was at the first time that it was attempted. The level of evidence, class of recommendation is class 2B. This is interesting that his bundle pacing may be considered as an alternative to RV pacing in patients with AV block with EF more than 40% who are anticipated to have more than 20% ventricular pacing, class of recommendation 2B. The rationale here is that the MOST and the David trial told us that patients who received more than 40% ventricular pacing were at higher incidence of heart failure. Subsequent studies by Keel told us that even 20% ventricular pacing puts our patients at risk of pacing-induced cardiomyopathy. Hence, the threshold as electrophysiologists must diminish and we must adopt conduction system pacing even in those patients who have preserved ejection fraction. So I would like to show this diagram, and it's a very nice schematic representation in a recent publication that those of our patients who have left bundle branch block, it goes without saying that CRT continues to remain the mainstay. However, for the want of finances, if there are certain issues, you may consider his bundle pacing. When should I consider left bundle branch pacing is if I have done his bundle and I'm unable to correct the left bundle branch and my patient's correction threshold continues to remain more than 1.5 volts at 1 milliseconds. Supposing despite left bundle branch pacing, I am unable to recruit the left bundle, I must shift to a hot or a lot CRT wherein we have one lead in the his bundle and one lead in the coronary sinus. But what do I do with my patients of right bundle and IVCD? Here is the entry of my conduction system pacing much sooner. My patients who have right bundle, I would want to offer them his bundle pacing. And supposing I'm unable to correct their right bundle, I would like to consider pre-exciting the right ventricle by placing an RV lead and giving them his bundle and RV lead to achieve optimal resynchronization. Similarly, in my patients of IVCD, I would like to consider hot or lot CRT at an early stage. Thus, to summarize, CSP is a promising physiological alternative to RV pacing and to CRT. There is accumulating evidence for its effectiveness, and it is likely to play a growing role in our practice. As I mentioned, information is still scarce and long-term performance is less. Tools are still limited, are under development. RCTs are still lacking, and we have to establish them further. While we know that CRT is an established therapy, ESC 2021, which has just gone by in the month of April, therefore thought that at this stage, there could not be any strong recommendations level 1 or 2A. Because of the data, we need more data. Data on LBB area pacing is scarce, and they have not made any recommendations regarding LBB area pacing at this stage. I'd like to conclude here, and thank you for having me here.
Thank you, Dr. Aparna Jaiswal. A very good justice to the subject. It's new and replacing it in another established therapy, and it is time to catch up with this new modality. Before giving the mic to the others, I have one question. where do you place when you have to go for hot?
When you're going for hot CRT, the
In the
plan
coronary sinus. On the
Yeah.
coronary sinus, your placement.
Yeah. So what you do when you're doing a hot CRT, whenever we do a hot CRT, the plan typically is I am going to do a His bundle branch area pacing. Why you are adopting a His bundle pacing is because you realize that the anatomy is not suitable. So you position a His bundle lead. After you position the His bundle lead, if your left bundle branch is not recruited, you go into the coronary sinus. You are aware that within the coronary sinus, you are bound for some challenges, and that is the reason you may have adopted for His bundle pacing. It's a class 2B recommendation right now. So when you achieve this, the studies that have been done with hot CRT, the trial that was done hot CRT was truly a very small number. We had only 29 patients and there were crossovers. So today I will think that the challenge does remain on the coronary venous anatomy, yet one must attempt to enter the lateral or the posterolateral vein. There is data to suggest if your patient has left bundle branch block with left axis deviation, you may even go into the anterolateral vein even and achieve a good QRS narrowing.
Any other or expert analyst, please?
I have a question to Dr. Jaiswal. Actually, we are interventional cardiologists and we are not an EP center. Do you recommend us doing LVP pacing even in a non-EP lab? Is it possible for us?
Yes. So typically what happens is how in the initial phase, the best way to do a His bundle or a left bundle branch area pacing is to have a quadripolar His catheter in the His area. Now, it really helps you because it delineates your His bundle potential. Once you see the His bundle potential and you are in an RAO 40, you know where you need to go into the left bundle branch area pacing. However, supposing you are not able to do that and you are very keen to do left bundle branch area pacing and you don't have an EP system, at the very outset, you can still attempt, you can surely have a quadripolar EP catheter. You don't need an EP system. You go into the area and just abut it across the tricuspid valve, look in LAO 40. In LAO 40, it should be looking at you at 6 o'clock. It gives you a very good guide where in that patient is His area. And then you draw a line from the tip of His catheter to the tip of the RV apex and go 2 centimeters below. Supposing you don't have any of this and you still want to do left bundle branch area pacing, you can still attempt. Now, what you need to do is you take your catheter and you enter the right ventricle. Once you enter the right ventricle, you have to look and you want to position it below you have an orientation in the LAO view. You have to orient yourself in LAO 40. In LAO 40, you need to abut the sheath and just the lead out of it. In LAO 40, you should have an orientation of where the His is kind of in your mind. And then when you begin to screw the lead there, you would want to look for the presence of a W pattern. And as you keep screwing it in, you would want that the screw should allow change of the morphology of a W to the change of a QR when you are entering on the left side and you're capturing the left bundle. You will induce and you will produce an incomplete right bundle branch block. So those are things, but I will truly suggest that in the initial few cases, it may be a better idea to involve an electrophysiologist and do a few cases, and subsequently you may want to challenge yourself without them.
Okay. How do you assess that the patient has not got extensive distal disease where it will not act?
Yeah, so are you talking of scar?
His bundle pacing or bundle branch pacing will not be effective if there is distal his Purkinje system is severely involved.
Yeah, so what happens? Yeah. So this is very interesting that how is it that when we used to see left bundle branch block, we always believed that it was an infrahisian disease. And how is it that by capturing a His bundle, you can eliminate a left bundle branch block? So that's very interesting. And what they have noted is that it is much early in the proximal area of the His that they the proximal area of the his, the bundles have already been delineated and they are already chosen which will go to the left and which will go to the right, and the disease in about 60 to 70% is truly proximal. It is only in about 30 to 40% of the disease that the disease is in the distal bundles. That is why they have seen that no matter what you do, when you do his bundle pacing or you do left bundle branch area pacing, you may not be able to recruit the left bundle branch because the disease is distal. But in a 2/3 of the patients, the disease appears to be in the proximal segment of the his bundle, where the fibers have already been predetermined which one will form the left bundle and which will form the right bundle.
Thank you so much. Any other question from the expert panelists? Okay, that was a nice lecture. I think the next speaker should come forward. Dr. Kamal Sharma.
Hi, good evening, everyone. Respected chair and dear friends, thank you for having me. So after this session on deliberation, which has always been talking about costing, I think I'm the odd one out who's going to talk about why the cost should not matter when you have to choose the APT. So when you do a complex angioplasty, we'll look at the need for original ticagrelor and why you would be interested in looking at the original brand of ticagrelor and how ticagrelor original versus the non-original would differ, unlike SGLT2s that we discussed, where the chirality probably is not the important aspect. So I'm going to touch upon the chirality of the molecule and then how it's imperative that when a complex PCI is done for a procedure, you would not be very keen to saving on that money. So this is like a case report from our own patient, 56-year-old male, diabetic, 5 years, known case of hypertensive, already on amlodipine and metoprolol. Early CKD eGFR of 60, presented with acute inferior wall MI with RVMI class 2, with window period 7 hours, pulse rate of 50, second degree AV block, pushed with an atropine, taken into cath lab, blood pressure 90/55. A patient was preloaded, of course, with aspirin, crushed ticagrelor. This is what we usually do. There have been small studies to tell us that ticagrelor, when given crushed in emergency department, was swallowed, the serum levels are achieved much quicker. And of course, remember that this was a case of second degree AV block, but this did not desist us from giving ticagrelor because we knew the etiology to be ischemic rather than AV nodal or AV block. 80 milligrams of atorvastatin again is something that we all do load with. And the anomalous RCA was actually coming from the left cusp, was the culprit, with ostial 80% with 99 mid RCA to TIMI2 for proximal part. So patient underwent the primary PCI transradially with EBU 3.5 with 3.538 DES, and a stage PTC to the LAD was done later on. So you can see that even my left system is actually the dye that is percolating through. The left and the right are actually arising from the left cusp itself. And this is the one which is once fixed up. You can see how big the vessel was and why the patient was having rhythm disorder. And of course, then later on, patient underwent a successful PCI to the LAD. Now, the issue is that post-PCI, of course, the patient is relieved and stable and then sent home. But are the ticagrelor brands the same? I mean, would you still, in such a case that you've just tackled out, would still be considering cost and switching to a debatably a generic equivalent of ticagrelor, which can also be an alternative, which a lot of companies actually do claim. So is the chirality missing a link? Now, unlike a lot of other molecules, the problem with ticagrelor is it has got a 6 chiral center, which is like 3-dimensional orientation. So you can have a left curve and a right curve, something like that. So you have 64 possible stereoisomers for the 6 chirally possible ways. So there are 63 ways that the key is not going to fit it in the lock. So when you look at the P2Y12 receptor ADP interaction, you would be choosing a key that fits exactly into that receptor hole. And if you have a slight change in that, you would probably not be expecting the lock to be locked or opened up as good or as inhibited as good the original would do. So I'll be touching upon 3 important aspects. What evidences do we have for the generic equivalents? Firstly, the pharmaceutical equivalence. Would that translate into bioequivalence, and will that translate into a therapeutic equivalence? First of all, how the drugs or the chirales or the generic equivalents are allowed in various parts of the world are very different. Like in the United States of America, you are not allowed to send a generic just based on your pharmaceutical equivalence. You'll have to show not only bioequivalence, and in certain important drugs, you might have to be proving your therapeutic equivalence. While in some part of the world, only pharmaceutical equivalence would do as good and to allow the generics to come into the market. So what does the variation of minus 20% plus 25% of bioequivalence means in platelets? Because equivalence is by definition defined as allowability of the drug to be equivalent in this range. So if a drug is 100, you are okay to go with bioequivalence of 80% to maybe having 125%. So when you have in terms of cardiovascular drug, like an antiplatelet, if you decrease bioavailability, of course, you have decreased platelet inhibition and you can have more ischemic rates. But then on the other hand, if you have increased amount of drug, and I'll touch upon the example of clopidogrel, how it has happened, the increased platelet inhibition can also lead to increased bleeding. Now let's look at the Indian scenario. And this is classical clopidogrel example, and we remember the original brand. And this was a Kerala study 2020, which looked at the actual amount of active ingredient in clopidogrel. And you can see that brand D, E, etc. can have the bonuses of the drug, more drugs actually coming through for the same amount of claim. So that also is not equally good. And you actually can have only a lot of 3 brands actually that could pass to have the range of purity ranging from 98 to 91 to 101%. But beyond that, it was not. So will the quality have an impact in the outcome? Let's answer the 3 broad-based evidences. So one, is there similar platelet inhibition with the generic and innovator oral brand? Second, is there similar incidence of clinical outcomes, say stent thrombosis, between the two? And do they have similar efficacy? Now, sorry. Let's look at the bioequivalence in real world for clopidogrel. So significantly higher incidence of high platelet reactivity has been shown with generic OAPs. This is a study published by Morrissey et al. Of almost 1,600 odd patients with ACS, of which 765 were STMIs. And then there was significant higher percentage of patients who had higher platelet reactivity with ADP after the administration of clopidogrel generic as compared to the original brand, with a significant difference, almost 17% difference with p-value of 0.001. So this high platelet reactivity by adenosine in the platelet aggregometer, which was classically defined as 10 millimoles, inducing 70% inhibition, actually did not hold the ground even in the Western literature for the generic equivalent. Clustering of the cases was also reported. Again, this is a publication from Kovac et al. And then they showed that these acute and subacute stent thrombosis actually increased in that part of the world after the introduction of generic clopidogrel. So these are 1,054 PCIs, and they were looking at definite stent thrombosis, which is 0.38%. And compare this with their historic data, only 0.14%. I mean, their operators were same. Stents were almost the same, and actually probably better, because this was being assessed after the original drug was replaced by generic equivalents, but stent thrombosis had gone up by 2.7-fold higher levels within 30 days, which is 3.2 times increase with generic clopidogrel, reaching a statistical significance. So this study of acute stent thrombosis by Kovac et al. Had shown that at Mount Sinai, when they compared even from the retrospective data, there was a statistically huge significant difference in the incidence rates. But this there was a trend for definite stent thrombosis for generic clopidogrel reaching to the same. Mortality and adverse events with generic clopidogrel was again published as a paper for the adverse event reporting. And when you look at the literature there, study comparing primary causative adverse events with branded versus generic in US FDA reporting system also showed not only the issues with that, but definitely higher amount of skin rashes that we very often find in our part of the world as well. 5% of the patients do come with skin rashes with clopidogrel, and the hemorrhagic complications were actually higher. So even if the generics were, not under built for the amount of dosages, they were causing more bleeds by 10%. So when you compare similar aspects for the experience for the RCTs, evidences, real world evidences, and approvals, probably extrapolating the same, we don't even have literature for generic ticagrelor, but for the innovator ticagrelor, we do have that. So coming back to the case with an emergency patient, when he walks into my cath lab, he was given a crushed ticagrelor rather than just loaded. Angiographic occlusion had revealed occluded to the doing RCA, which was tackled. From another patient was one that we had was on previously a generic brand, which we had to do PCI. That case, we had to do thromboaspiration because of the stent thrombosis. We did an IVUS imaging, and we found out that stent was well expanded. So if you blame the drug to be responsible cause, then you will have to think that maybe the generic substitution was one of the reasons. So to summarize, the points that I'm trying to raise based on the chirality is that ticagrelor, which is known to reduce not only CV mortality, but even acute stent thrombosis rates, bioequivalence may not translate into therapeutic equivalence, and risk is high in such cases where you're using therapies like DAPTs. I think sticking to the original band will work well. Thank you. Thank you very much for patient hearing. Sir, I can't hear you, Dr. Mukherjee. I think you're muted.
Deepamanda, unmute yourself, please.
Dr.
Unmute
Deepamanda,
yourself.
you're muted. Can't hear you.
Okay.
Yes.
Okay. So if the chirality is the issue and the original brand is to be replaced by any other brand, you may have to land up with this crisis. That is true. That is really true. Any comment from the experts? Okay. The next speaker is Dr. P.C. Manoria, and I request Dr. Spandan Bhaduri to be taking up the issues. Dr. P.C. Manoria did not have any introduction. He will be speaking on dapagliflozin in presence of cardiorenal metabolic continuum. Dr. Manoria, please. Then no sound is coming.
Just a minute.
Okay, unmute.
Slides are visible.
Yeah, yes, sir. Yes, sir. Perfect. Sir.
Are you able to hear?
Yes.
Okay. So good evening, everybody. At the outset, I would like to thank the organizers for inviting me to this wonderful conference. So for the next 10 minutes, I'll be talking on, is dapagliflozin a panacea for cardiorenal metabolic continuum? All of us know cardiorenal metabolic continuum is commonly seen in diabetic patients, but is also seen in non-diabetic patients. So in diabetic patients, there is often a close cross-connect between diabetes and heart failure and CKD, diabetes and NAFLD, and obesity and diabetes. All of us know diabetes commonly results in heart failure. Patients with heart failure are at increased risk of diabetes. Worsening heart failure worsens kidney failure, and worsening kidney failure worsens heart failure. And type 2 diabetes produces NAFLD, and NAFLD predisposes to type 2 diabetes. And obesity is a very important determinant of insulin resistance and diabetes. Interestingly, SGLT2 inhibitors target all the three components of the cardiorenal metabolic continuum, as I'll show you. So what are the benefits in the metabolic component of the cardiorenal metabolic continuum? SGLT2 inhibitors, particularly DAPA, reduces HbA1c, decreases glucotoxicity, reduces weight, reduces visceral fat, increases insulin sensitivity, decreases blood pressure, And this is achieved with minimal or no hypoglycemia. And interestingly, they also decrease new onset diabetes. Now, this shows that the HbA1c with dapagliflozin is decreased from 0.84 to 1.32. And this is achieved whether you use dapagliflozin as a monotherapy or as an add-on therapy on any other anti-diabetic medication. The weight is also reduced from 1 kg to 3.4 kg. And there's also reduction in the visceral fat, and blood pressure is also reduced by 3 to 4 millimeters. And this benefit is maintained for 4 years, whether you are talking about HbA1c reduction, or you are talking about body weight reduction, or you are talking of blood pressure reduction. And this is achieved with minimal or no hypoglycemia. And interestingly, the DAPA-HF trial, as you can see, showed a 32% reduction in the new onset diabetes. What is its benefit in the cardiorenal spectrum? This will be talking on the DECLARE trial, which was for prevention of heart failure, DAPA-HF for management of HF, and DAPA-CKD for management of CKD. Now, in heart failure, SGLT2 inhibitors are a panacea. They decrease hospitalization for heart failure in CV outcome trials. They improve heart failure outcome in HFrEF patients, and they decrease hospitalization for heart failure, CV mortality, all-cause mortality, and also improve the quality of life. Trials in HFpEF are ongoing, the DELIVER and the EMPEROR Preserve. This is the landmark DECLARE trial. 17,000 patient DAPA was compared 10 milligram with the standard of care, and 60% patients had only risk factors, while 40% patients had ASCVD. The primary endpoint, hospitalization for heart failure and cardiovascular death, a statistically significant reduction of 17%, and in the atherosclerotic MACE, there was no significant reduction. Decreasing hospitalization for heart failure is a great achievement in the treatment of heart failure, because every hospitalization, every rehospitalization takes the patient closer to death. And this is the subgroup analysis of post-MI patients, which shows that there was a 16% reduction in the MACE. And DAPA produced benefit whether you have a history of heart failure and irrespective of the ejection fraction. The mechanism, all of us are familiar. It acts in diverse ways and is approved and available in several countries around the world. This is the DAPA-HF trial. All of us are aware of it. Here, DAPA 10 milligram was compared to standard of care placebo, and the trial was prematurely terminated because of immense benefit. 45% were diabetic, 55% were non-diabetic, and there was a 26% reduction in the composite of cardiovascular death and worsening heart failure. Cardiovascular death was reduced by 18%, hospitalization for heart failure by 13%, all-cause mortality by 19%, and the benefits were achieved within a month. And the drug was very well tolerated. There was optimized background standard therapy. It was tested in all substitute patients, as you can see on the slide. And the first big message from DAPA-HF was that the drug was effective in non-diabetic patients. Whether you are diabetic or non-diabetic, the benefit is same. There's a 25% reduction. The second big message was it was effective even on top of ARNI. And again, you can see the benefit is same whether ARNI or not, 25% reduction or 26%. And the third big message, which needs further investigation, is DAPA-HF has shown that dapagliflozin can postpone device therapy with the results we have obtained. The quality of life was improved. Side effects are minimal, it's very well tolerated, and the benefit in DAPA-HF was seen across the entire EGFR spectrum. Now, this is the sequencing, which was partly discussed in the earlier lecture. The conventional switching we do not practice because it takes long time. This is the switching which is proposed by McMurray and Dr. Packer, in which SGLT2 and beta blockers are preferential agents and followed by ARNI and MRA. But the ACC consensus recommends ARNI as a preferential initiator. But what is more important is whatever may be the sequence definition, all these four foundational fantastic drugs should be on board depending on the subset of patients. And this is decided by the blood pressure, by the EGFR, by the potassium and heart rate. So sequencing may be different, but all 4 drugs should be on board within a period of 4 to 6 weeks. And polypharmacy is the rule in HFrEF, and the patient and family must be motivated right from the beginning. Escalation should be the goal in HFrEF, because diabetic heart failure survival 5 is only 15%, non-diabetic is 15%. So even if the patient is less symptomatic, one should not de-escalate the therapy. And DAPA can be used across the spectrum, cardiorenal spectrum. Stage A heart failure, it decreases these 3 risk factors. Stage B, stage C, it decreases hospitalization for heart failure, cardiovascular mortality, all-cause mortality. 3-point MACE was also shown to be decreased, and their progression of kidney disease is slowed down. And if you use all these 4 drugs in a 55-year individual, you can increase the projected survival by 6.3 years. It has been approved by various professional bodies, the HFA ESC, the Canadian guidelines. Now, what are the renal benefits? The peculiar benefits in the kidneys are that it slows down the trajectory of CKD by slowing decline in the GFR. Postpones dialysis by 10 to 15 years, decreases hospitalization for heart failure and CV mortality and all-cause mortality. All of us know normally eGFR is 0.9 ml per minute per year. When CKD sets in, it falls down to 10 ml. And when RAS blockers and SGLT2 inhibitors were not available, most of these patients were subjected to dialysis within a short spell of time. But the first revolution came with RAS blocker in 2005, and it slowed down the decrease in eGFR from 10 to 4.59, which was a great achievement. The second revolution came with SGLT2 inhibitors in 2015, and this further slowed down the decline in eGFR by another 58%, shifting eGFR decline from 4.59 to 1.85. And this gave a good opportunity for CKD in diabetic and non-diabetic patients, as shown in CKD, which I will be discussing. And the third revolution is now with non-steroidal MRAs, Finerenone. The Fidelio trial has shown improved cardiorenal outcomes. And this is fascinating, is if you use SGLT2 inhibitors on top of RAS, you can postpone dialysis by 15 years. And this is a very, indeed, a great achievement for CKD patients. The renal benefits are seen whether you are looking at the cardiovascular outcome trials, that is the AMPERAGE, the CANVAS or DECLARE, or you are looking at HFrEF trials, the DAPA-HF and the EMPEROR, or you are looking at the dedicated CKD trial, that is the CREDENCE and the DAPA-CKD. And this is the famous DAPA-CKD. DAPA 10 milligram was compared with standard of care. CKD patients 25 to less than 75 eGFR and UACR more than 200 to less than 500. And you can see the composite cardiorenal endpoint decreased by 39%. The curve starts separating in 7 to 8 months. The renal endpoint is a 34% reduction. And most of the CKD patients die because of cardiovascular event. So cardiovascular death and hospitalization for heart failure is also decreased. All-cause mortality was also decreased. And this shows that DAPA has shown reduction in the composite cardiorenal endpoint, the renal endpoint, the all-cause mortality, and the CV mortality. So in summary, DAPA has completed the whole circle. DECLARE trial is with primary and secondary prevention. DAPA-HF in HFrEF, and DAPA-CKD in non-diabetic as well as in diabetic CKD. So the big message for the cardiorenal metabolic continuum is that SGLT2 inhibitors is a panacea for improving cardiorenal metabolic continuum. They have initiated dawn of a new era for improving cardiorenal metabolic health. Thank you very much.
Thank you, Professor Manoria. That's very, very good lecture and educative. We are running short of time. Dr. Amal Khan. Dr. Amal Khan,
Nice to see you after a long time.
Nice to see you.
Okay.
And still in action.
So we are late by about 35 minutes.
Just
and our
just one comment.
Dr. Majumdar, you
Just
take
one
up.
comment. Thanks, Professor Manaria, for excellent talk and giving all aspects of cardiovascular and renal benefit. So one recently published trial in the SEC has shown sotagliflozin, that is SGLT type 1 and type 2 inhibitors, reduction of heart failure in all ranges, starting from heart failure with reduced ejection fraction to heart failure with preserved ejection fraction. So DAPA heart failure with preserved ejection fraction is going on. We are probably we will probably get some positive results. So some form of management in patient with heart failure with preserved ejection may also come from this molecule also.
Both these trials have passed on three big messages. The message number one was that sotagliflozin, when was initiated in ADHF patients after hemodynamic stabilization, 2 days prior to discharge or 2 days after discharge, there was significant improvement in the CV outcome in terms of hospitalization for heart failure and cardiovascular death. The second big message that you said, improvement was seen in HFpEF patient, and this is indeed a great exciting news. And the third thing, that MI and CBA was also reduced in the SCORE trial, which is usually not the story of SGL. So atherosclerotic events were also reduced. So both these trials showed three new data, and I think in times to come, just as RD got approved for ADHF, the EMPA and the other SGLT2 inhibitors, the trials are ongoing. They may also be utilized in ADHF after hemodynamic stabilization.
Thank you, sir. Thank you for excellent talk.
I think we are complete with all the speakers. Our next speakers are already on. So we thank all the speakers and the chairpersons and the experts and the moderator. Next session, please.